Okay, here's our first question for the critical thinking for Chapter 8. When would it be appropriate to code a V code for a screening examination? And what are some common examples of screening examinations? Well, the only time it's appropriate is if there is no sign, symptom, abnormal finding, or diagnosis to code. The physician will usually use the term screening, and most commonly these are done for annual mammographies and DEXA bone scans, which are used to check the osteoporosis in older women. The tests performed will also be specific screening tests versus diagnostic tests done on the basis of a sign or a symptom. Another instance would be screening for colon cancer because of a patient's family history of colon cancer. In this case, the V code for screening would be coded first, with the V code for family history of cancer coded as a secondary diagnosis. Okay, our next question. What are some examples of when it would be appropriate to query a physician as it relates to signs and symptoms? Well, one example would be if chest pain were the only diagnosis documented as the principal diagnosis. Perhaps the patient is on medication for gastroesophageal reflux or has trouble breathing along with the chest pain. In these situations, the coder may want to query the physician for the etiology of the chest pain and have him or her document this in the progress notes. For instance, the patient's true severity of illness and need for resources are best documented by establishing an etiology. Some common causes for chest pain are CAD, GERD, pneumonia, pleurisy, pericarditis, and pulmonary embolism. Even if the physician documents probable for any of these diagnoses on the basis of inpatient coding guidelines, it would be appropriate to code. Following that same way of thinking, another example would be fever, with potential differential diagnoses being pneumonia or UTI, depending on other symptomology. Okay, here are a few coding tips for the information covered in Chapter 8. V codes help explain why a patient is being seen when the visit is for circumstances other than a disease or injury. In other words, the patient is not currently sick or hurt. Typically, there are no more than 2 or 3 V codes used per encounter. V codes are used in all healthcare settings. Some V codes can be sequenced as the principal diagnosis or secondary diagnosis, while others can only be sequenced as a secondary diagnosis. See Section 1C18E of the OGCR for a list of V codes that may only be sequenced as the principal diagnosis or first listed diagnosis, and review the OGCR for different categories of V codes and when each can and cannot be used. Okay, following are examples of common uses of V codes used as the principal diagnoses, meaning that typically the patient has no signs, symptoms, or abnormal findings. And the first example is a follow-up. The patient has a history of colon polyps and is now coming in for a follow-up colonoscopy to make sure there is not a reoccurrence. And second, supervision. A pregnant patient has a history of infertility and is scheduled for her monthly checkup. Supervision of a high-risk pregnancy. And then in aftercare, a patient is having an internal fixation device removed that was placed 6 weeks ago. There is nothing wrong with the device itself. It has just served its purpose and is now scheduled to be removed. Planned aftercare to remove a device. Okay, now if a baby was born in the hospital, that encounter requires a V code as principal. However, if the baby is transferred to another hospital, the receiving hospital would no longer use the V code as principal. In this case, the receiving hospital would use the reason for the transfer, such as respiratory distress, sepsis, anomaly, etc. And finally, if a patient is in the hospital and it's necessary to rule out a myocardial infarction, it's significant that the patient has a family history of heart disease. However, in this case, it's not as significant if the patient has a family history of arthritis. Now, typically, teaching hospitals will want everything coded because data are often collected on many diagnoses. However, the small community hospital might not be as stringent in capturing each and every code.